Good evening, everybody. How are we all this evening?
Very good.
Fantastic.
Very good.
Good. Well, we've just got a couple of minutes before as we're letting everybody in. So welcome, everybody. Come on in. We've got this excellent panel of our colleagues this evening to give their little area of expertise. So I'm really looking forward to this evening. So just while you're coming in, just to explain, and I will explain just before we start again, but we've been using a different system with a QR code that will show you at the end of the presentation. So if you go through the QR code, answer the questions, and you get your certificate straight away. You need to tick any little boxes that there are, and also just to check your spam or other email folders in case it goes into there. So we've been doing hundreds by this system, but there's always the odd one or two, and I'll put an email into the chat that you can just jot down in case you've got any issues, and we'll sort that out for you. So I think we'll start the evening. We'll just we'll keep it on time this evening because I know you're all busy, new kitchens and children and all so on. Thank you very much and welcome to the Ikigai webinar series. We ran this last year and, you know, it was really successful. We had so much positive feedback on it. And like I say, you all bring your own little area to it. And, you know, and I think heightening awareness with us. And what we were just talking about before we went live is that if anybody wants more information or if you'd like longer sessions, we'd definitely be open to looking at that with the panel here. So let's introduce ourselves. And as I see it on the screen, I have Joss first.
Hello, good evening. Thank you very much for inviting me to be part of this amazing panel this evening. My name is Joss Harding. I'm a dental hygienist and I'm President-elect of the Mouth Cancer Foundation. I work part-time clinically in a private practice, and the rest of the time I'm either giving presentations or working for the charity or writing bits and pieces or just trying to raise awareness about the mouth care for cancer patients and the mouth care for head and neck cancer patients. Thank you very much.
Thank you, Joss. Incredible work that you do. And Imogen?
Hi there, I'm Imogen. I'm a dental hygienist and a dental therapist. And I worked for Macmillan as a dental therapist at the John Radcliffe Hospital for 7 years. And I now work for King's College Hospital within special care dentistry. And I got into this essentially because I've got a real passion for caring for patients who've experienced cancer, having had that experience with Macmillan. And hopefully I can share some of that with you.
Thank you, Imogen. And I've got Emma next on the screen.
Hi everyone, my name's Emma Riley. I am a dental nurse, a proud dental nurse, and my past role, I was the Macmillan oral health educator for the UK at the time. My passion today is for the older person, so I'm just going to go through a few points in how we can look after people over the age of 65 who are suffering with this condition. Thanks for having me.
Thanks, Emma. And Alison?
Yeah, good evening. I'm Alison Brown. I'm a dental hygienist down in Cornwall, and I'm an ambassador for the Mouth Cancer Foundation. So I work in private practice, and I also work at Peninsula Dental School with the Year 4 students. And I'm quite involved in obviously making awareness of head and neck cancer, but also communication and barriers that maybe affect our communication. And I got into that through just doing some research within my practice and wondering why we weren't talking about it. So that's my background.
Excellent. Imogen, we'll get you set up and ready to go. And just to explain again that at the end of the presentation, there will be a QR code that you can just scan. I'll also put a link into the chat. You will get your certificate straight away at the end today. If you have to go off for any reason, it is available on demand in about 7 to 10 days. So yeah, let's get going, Imogen.
Okay, I'm going to share my screen. So Okay. Being a bit slow, hang on. We practiced this 3 times before and it's not liking it. It's typical, isn't it? Right.
Can you see the bar at the bottom? Yeah.
Ah, there we go. We're off.
Yeah.
Okay.
Okay.
So, hello everyone. Thank you so much for coming and joining us today. My name's Imogen, as I said, and I'm a dental hygienist and dental therapist. And I'm going to talk about something this evening that's very close to my heart and also at the heart of patient care and giving empathetic communication, especially when working with patients who are affected by cancer, and how that can affect the relationship that we have with our patients and how we can support them better by having that empathetic care. So the reason I got into doing this, I suppose originally once upon a time, was that my own grandfather unfortunately died with head and neck cancer. So when I was around 11, he passed away, and I saw not just his challenges and his struggles, but also the challenges and struggles that my own family experienced. And seeing someone who was a very confident, very handsome, successful man turn into somebody who people were nervous of looking at in the streets, who couldn't communicate, my grandmother becoming much more isolated socially, it really was very challenging. And so I suppose this is how I kind of became interested in how we can support these kind of patients. So having experienced that, when I qualified as a dental therapist, I started working for Macmillan as a dental therapist. And I was based at the John Radcliffe for 7 years. As I said, I now work at King's Community, and I also work in private practice. So the aim of my presentation is to give people the confidence to open up and have emotional and sensitive subject conversations with people, to get conversations started between our dental team as well. This isn't something that we do alone. To improve our patient experiences, we really need to work as a team. And that means that hopefully we can share these conversations with our colleagues as well. And the goal inevitably is to therefore enable dental professionals to give truly empathetic care. So the objective, hopefully at the end, you'll be able to describe what compassionate empathy really is and have a general understanding of the approach to difficult conversations and how we can have that a sort of compassionate, gentle conversations about such a sensitive subject. I will also talk a little bit about the side effects of radiotherapy for head and neck cancer patients, as that really links in with how we can become empathetic. But the other ladies in the panel have got a lot more to share, which I think will build on what I'm going to start on. So to start with, I think one of the pitfalls that we fall into is that when we talk about empathy, we really think that there's only one form of empathy, to be empathetic. But actually there are 3 different types, and having a gentle understanding of the differences between these things can really help us to hone in on those skills and understand where we're excelling as a clinician and perhaps where we're letting ourselves down. So as you saw from the slide, we're going to start with cognitive empathy. Now, I think with cognitive empathy, we kind of all feel that we understand what somebody is going through. And particularly as clinicians, this is a very kind of common one for us to naturally lean on. So when we're having conversations with patients, we inevitably start off by trying to put ourselves in their shoes, trying to understand what is it that this person is going through. And by doing that, we are able to give a level of empathy, but we keep our guard up. And unfortunately, in the process of doing this, we can become quite robotic. And we end up essentially over simplifying the empathy that we're giving so that we can give very clinical, clear suggestions, perhaps practical solutions for our patients. And it can become very robotic and very disconnected. And so that patient really feels that you perhaps understand what they're going through, but not really what it is for them, how their feelings are involved in that. The next type of empathy is emotional empathy. And this is one that as clinicians, we are nervous of. So in other words, what happens here is when you see somebody smile, it makes you smile back. When you see somebody cry, perhaps it tugs at your heartstrings as well, and you feel unhappy as well. In other words, you're sharing that person's actual feelings. And the problem that we have with emotional empathy is in dentistry, we quite often can suffer from emotional burnout in this situation. So we as clinicians, we have to have good control of our own feelings to prevent ourselves from essentially becoming overwhelmed by our own emotions and therefore unable to give the support to our patient that they require. Also, it doesn't look very professional, of course, if we become overburdened by our own emotions. And essentially what we're trying to do is bring these things together to create compassionate empathy, which is the goal that we really are all aiming towards. So compassionate empathy is joining together these concepts. It's, I understand your situation, I feel it with you, and I'm here to help you in whatever way you need. So doing this combination, it enables us to bring trust and deepen our rapport with our patients, and it makes our job considerably more rewarding. So why does it matter? Let's be honest, you know, we aren't routinely trained in empathetic communication within dentistry. So dentistry usually it's focused on technical skills, clinical practice, delivering evidence-based procedures. And if we are hit with, you know, an emotionally deep comment from a patient, which does happen, particularly as hygienists, I think, because we spend longer with our patients, we might get to patients say when we ask them, how are you? They tell us, my partner's got cancer, or I've just been diagnosed with cancer. And as clinicians, when we're not prepared for that, sometimes we can find ourselves freezing. We can find ourselves brushing over it somewhat and kind of avoiding going into it too heavily to avoid discomfort and awkward conversations. And so inadvertently, in our efforts to stay professional and in our efforts to avoid awkwardness, we can find ourselves accidentally downplaying and undervaluing what is going on in that patient's life. And we end up with a bit of a script, I suppose, as clinicians, and we can find ourselves leaning so heavily on kind of what we feel comfortable saying to them that we can very much easily slip back into that. So what I hope that I can do or touch on a little bit today is just making sure that we have a little bit of an understanding of how we can deliver empathetic care while avoiding burnout, because we as clinicians need to also think about ourselves. And it's one thing if we see perhaps one patient in a blue moon who has an emotional situation, but there will be people out there in the audience who are watching this because perhaps they already work in a head and neck cancer setting, or they deal with a lot of elderly patients, or perhaps they're seeing a lot of patients who have complex health issues or are more likely to have difficult circumstances. And so although this is focused on head and neck cancer cares or cancer in general, we can use these skills very versatile way to support our patients who are going through all sorts of difficulties, perhaps a divorce or other personal circumstances that they may talk to us about. And the first step in delivering that empathetic care as a clinician is to understand what the patient is going through. So this is the aspect of our cognitive empathy, understanding what is this patient going through. And so because of that, I'm just going to touch very, very slightly. The other ladies will go into this in more detail. Particularly, I think Joss talks a little bit more about what the patient's journey is like. But in essence, what we need to think about is if this patient has come to us, they've said, you know, they've had a whole course of treatment of head and neck cancer, perhaps. It's very easy for us to think, oh yeah, I know what that looks like, fine. But do we really know what that patient has gone through? So once this person has had a lump perhaps spotted in the clinic chair, they are sent for a referral, then a biopsy, then scans. They have huge discussions in an MDT setting, so multidisciplinary team, where many, many different clinicians and experts will come in and talk to that person. They'll have a dental assessment within that hospital setting, perhaps being advised to have multiple teeth taken out. They may have to have a peg fitted, which is a way of feeding directly into the stomach, if it's likely that they're going to become unable to eat properly. They may have then had to have surgery, facial surgery, neck surgery that really changes their appearance, perhaps means that they can't eat properly, speak properly, losing multiple teeth perhaps. And then after all of that, they may then go into having radiotherapy for 6 to 8 weeks, perhaps combined with chemotherapy. And then they're sort of churned back out and sent into general practice. And there we are, we find them sitting in our chair saying, oh, I had radiation treatment and I had head and neck cancer. And we say, oh, that's awful, you poor thing. Is that really enough? Do we really understand what that person has gone through? So this is just a very quick snapshot, a couple of little gruesome images for you, just to paint a picture of what this looks like, the aftermath of successful treatment. You know, for some people, they've gone through as I said, the peg feeding, perhaps they're now eating again. They've had 6 weeks of sitting with this mask on their face every day. And the after effects of radiation treatment are forever. This isn't something that they have and then they're fixed. So we do need to have a general understanding of what they've been through, and also an understanding of what they're going through now and perhaps long term. Trismus, changes in diet, taste, perhaps extreme xerostomia, perhaps they can't swallow, perhaps they don't even have a tongue, limited tongue movement if they do have a tongue. So these are really major, major treatment side effects that we as clinicians need to be able to help them with to our best of our ability. So perhaps we already know that this person has had a difficult time, perhaps we don't. But one of the pitfalls that we commonly fall into, as I said earlier, is a script. We often go to the waiting room and perhaps we'll say to somebody, "Hi, Mrs. Smith, how are you today? Come on in." And by saying, "How are you?" we are opening up perhaps a very sensitive subject for some people. And it's quite common for this to be a conversation that you're having while in a public space like the waiting area, and you're perhaps even got your back to them while you walk and you guide them into your surgery. So absolutely, we will have these situations that we can't predict. But if perhaps you already know that this patient has had a very difficult time or has undergone some recent cancer treatments, it's worth just taking a moment before you get them from the waiting room to consider, what could I say to this person to welcome them that doesn't make them feel uncomfortable? They may not want to share how they're feeling quite so publicly in the waiting space, or perhaps they might answer to you in a way that makes you feel uncomfortable by saying, "Actually, I'm not very well. I'm, this many weeks into cancer treatment," whatever. So one option that I found very useful was I would say, "Hello, it's lovely to see you. Come on in." And at that point, once they're in the surgery, we can start conversations in a much more private and careful way. So these are just some little ideas. I'm hoping that you guys will take from this what you want. Some of this comes very, very naturally to some people. For some people, it really isn't natural. But it's being more conscious of the word choices and the personal circumstance and being sympathetic to those people. So I'm not suggesting you have to use my script. Come up with your own, see how you feel. But try and avoid saying things that can make somebody else feel uncomfortable. Perhaps it's not thought through. Okay. So talking to people who talking to people with cancers, and these are people that I like to say they're living with cancers. So they may have gone through the treatment, that perhaps they're in remission, but their side effects are long-term, or perhaps they still have cancer. But when we find ourselves in these difficult and awkward conversations, it's better to say, I don't know what to say, than to say nothing at all. When we have that moment of freezing and not knowing what the right thing to say is, it is human and normal to sometimes not have the right response. And in my experience working with these patients for many years, and I saw many, many, many hundreds of patients over that 7 years, I sometimes would say, I don't know what to say. I'm really sorry. And that sometimes is best you could come up with, because there's not always the correct thing to say. The other thing to be conscious of is that although we want to create open conversation, encourage these people to feel comfortable enough to share things with us so that we can then signpost them correctly, and so that we can give them that support that we have inside us. You know, we have all this information, all this knowledge that we think I know lots about dry mouth. I want to share all these products that these people can benefit from, or oral hygiene instruction that this person really, really needs. Sometimes people don't want to talk about things. So they may have already told their story to 10 people already that morning, or they may have just burnt out emotionally already and feel actually they just want to do something very minimal today. So you can use phrases like, would you like to talk about it today? Or if you ever want to talk about it, I'm here. And that makes them feel listened to. It lets them feel supported, and it gives them the choice. Do we want to talk about it today, or do we not? And if you don't want to, that's okay. We can come back to it. We need to acknowledge their situation and make sure that they know that we understand that it's not an easy feeling for them, and that we're there. So talking to people with cancers can also, as I've said, you know, we can have a tendency in our awkwardness to downplay, and sometimes we can find ourselves over downplaying, perhaps saying, oh, don't worry, I'm sure it will be okay. And in doing this, we can really undermine and undervalue how that person is feeling in our efforts to perhaps try to uplift them. And it can feel quite, you know, it's a big barrier in feeling that they are understood. It really can break that relationship down very quickly. The other thing that we naturally do, certainly something that I find myself leaning towards and I try very, very hard to avoid, is telling our own story. So when we try to empathize with somebody, we're putting ourselves in their shoes. Sometimes there's a tendency for us to say, oh, I totally understand what you're going through because I had XYZ happen in my life. And it's okay to mention it, but just remember that this is their situation, it's their story to tell, and this is their moment. Particularly in a clinical setting, they've come here as our patient, so therefore we need to give them the opportunity and the time to talk about it. So the other thing that we need to make sure that we are doing correctly is getting our body language correct, okay? So body language here, we're talking particularly about taking off your mask, creating eye contact with your patient. Compassion isn't just spoken, it's shown. So if we're not showing compassion in our body language, it doesn't really matter what we're saying. If we feel uncomfortable, we can accidentally create barriers. So what perhaps could happen is the patient brings up something uncomfortable. The dentist or the hygienist, they turn around and they're washing their hands over here and they're avoiding kind of looking at the person. They're saying, oh, that's terrible. I'm so sorry. Tell me more about that. That's, you know, really difficult for you. The words that they're saying may be okay, but if they're not sitting and giving eye contact and getting level with them and actively listening to what that person is saying, it means nothing. We also need to create the right setting for these conversations. So we need to think about background noise. We need to be turning the suction off, asking our nurses to stop preparing the equipment and opening and closing the drawers in the back of the room, turning down the rap music and perhaps considering something a little bit more mellow and calm, or background music, or nothing at all. We need to make sure that we're giving them our full attention and that they feel that we are fully listening and engaged to what they're saying. Otherwise, they're not going to share anything with us. Then we need to touch again, I'm coming back to our emotional empathy. So we're building on that understanding, that cognitive empathy, understanding by listening to what the patient needs, asking them the right questions, and then we need to show our emotional empathy. Now, this is something that is a very difficult balance, and it's something that takes practice, but it's okay to show your patient that you're genuinely saddened by the news that they've shared with you. So it's not about you, it's about them. But if you feel upset by what they're saying, it's okay to look upset, to look emotional about what they're saying to you. There's a line, and obviously we don't want to start crying or being overly burdening them with our own emotions, but it's acceptable to feel sad for when someone tells you something sad. So the other thing that we need to think about is making that person feel a sense of normality. And this is something that I found extremely difficult when I first started working in a head and neck cancer setting. The aim is not to distract from the situation, but to give this sense of norm, this sense of there is more going on in this person's life than their cancer, that they are still a person and they are getting on with their lives as best as they can. So that means that we need to make sure that we don't feel stunted by the topic, and that we still talk about their normal interests and hobbies and find out about them as a person. So the same as we would with any of our other patients, I like to think we all do this a little bit. Perhaps we can ask, oh, what are you doing at Christmas? Are you staying at home? Do you have family coming? You can ask them if they've been on any holidays. Perhaps they may have had to stay in the UK, but perhaps they went somewhere up north to visit family. I don't know. It's worth asking these questions. Ask what their interests are. I've tried to include a little picture here with some inspiration for you guys, because perhaps they love music or painting. Perhaps they like gardening or walking, speaking with their family and their friends. So it's worth us just thinking about these other things that we can talk about. We need to try then to join all of this together, the information that that patient has wanted to share with us, and we need to be inviting them with open questions to lead us in the direction of what they might need from us. And this is a really, really important part of our care. We may have, as I said, lots of information, and certainly hopefully you'll have a little bit more to share about once you finish this webinar with this panel. And we want to share our experience, but we need to think about what's useful for them. So we might perhaps say, I can give you some information on xerostomia products. Would that be helpful? Or I can signpost you to a really good support network. Would that be helpful? And that they can say yes or no, but you can share with them that you have information that you can give them. So I'm slightly going over the same thing here, but basically what we're aiming towards is active listening, led by the patient. It enables you to meet their needs and to make them feel really listened to and supported. And that in itself is a huge part of compassionate empathy. So it may be that they need advice on diet, low sugar food ideas, managing dry mouth, resolutions for limited opening, signposting for financial support. There is a whole way, a vast catalogue of things that we can help them for. But the most important thing is really that we build that relationship through our empathy, through enabling these difficult conversations to feel more comfortable. And then we are really in a position where we can help them the best as possible. Thank you very much. I am going to stop sharing. Okay. And I'm going to pass back to Siobhan.
Yes, so Alison, whenever you're ready, you can upload your presentation. Thank you very much, Imogen. Very interesting, and it certainly makes us, think about the wording. And definitely, I've heard that presentation a couple of times, and it's definitely changed the way I speak to patients when they come into the waiting room. Yeah, a lot of people are saying thank you, Imogen. Yeah, so Alison, are you there? Okay, Jocelyn, if you're there, perhaps. Yeah.
I'm here. Would you like me to carry on?
Yes, please, if you don't mind.
Let's go. Right, so. Okay, so can you see the main screen there?
Yes, we can. Thank you.
Lovely. Thank you very much. Smashing. Just minimize. Oh, where have you gone? Sorry, beg your pardon. I minimized you and then lost you. Where are you? Ah, there we go. Right. Okay. So I'm going to talk a little bit. It's quite a brief part, my part of this, to talk about the State of Mouth Cancer UK Report 2024, a report from the Oral Health Foundation. And have you actually seen this document and have you had a good read? It's a very good read. The last one was 2 years before. And the nugget that I took from that was also that most patients, averagely head and neck cancer patients, their dental treatment over 5 years will cost the patients £1,500, which is quite shocking. And I'm going to pick out some nuggets in this report. So please feel free to go to the Oral Health Foundation and have a good read. There we go. Right. So the new cases of mouth cancer in the UK have reached over 10,000. So 10,825 last year. So this is where it's got over 10,000 the first time. These patients, and the numbers are creeping upwards, but where are these patients? These patients feel very isolated. So be prepared. These patients will be on their journey with their treatment. Please find a head and neck cancer support group near you, near your clinics. For me, I would always recommend the Mouth Cancer Foundation. It is Mouth Cancer Action Month this month, but for me, every day is Mouth Cancer Action Month. So please feel free to go to the Mouth Cancer Foundation for details, but there are many head and neck cancer charities around the UK, and find one local to you for your patients. This has increased by 38% in the last decade and by 133% compared with 20 years ago. So when I qualified in 1992 as a dental hygienist and 1987 as a dental nurse, I didn't know anything about mouth cancer. I'd never come across it before. And the first person I actually met was my father's best friend from school. And he'd had it, he was diagnosed with tongue cancer about 40 years ago and died very recently, but from other complications. But did I have the training? Did I have the knowledge to help him? No, I didn't. But I certainly went on a mission to help him. But 53% of mouth cancers appear on the tongue and tonsils. So are people looking at the tongue? Are they looking down the throat of the tonsils? Not. Tonsils aren't always easy to see, especially if we've got quite a wide mouth, we've got a big tongue. But have a good look, have a try. And last year, 3,637 people, sadly, in the UK lost their lives to mouth cancer. The 10-year survival rate is between 18% and 57%, depending on where the cancer strikes and how early it is diagnosed. Prof. Lewis says that you need to be able to find a tumour that's 2 centimetres in diameter or less for it to have the best outcome. Can we find them at that stage? Not often. So we need to listen to symptoms. The patient comes in and they're mentioning maybe a hoarse throat or something doesn't feel right, or they can actually pinpoint something and it wasn't there before and it started to be more problematic. Then please review in 2 weeks, and then if it's still there, speak to your colleagues, make sure your colleagues can have a good look. If there's something visible and you're actually able to take a photograph, then fantastic, and send it off with a referral, and then the patient will be triaged at the hospital. and seen promptly should there be any issues, and they're picked up as being not the 2-week wait's not called the 2-week wait anymore, but if they are it looks like it's something that needs to be seen urgently. So it's all about us making a difference. So let's make a difference. So in this oral health report, it said around 77% of UK adults have now heard of mouth cancer. However, when I ask head and neck cancer patients who've been diagnosed, they're on their journey with their treatment or post-treatment, I say to them, did you hear about head and neck cancer or mouth cancer or tonsil cancer or any kind of cancer of the head and neck? Have you heard of it before? Very few of them have actually heard of it. Awareness of the major signs and symptoms for mouth cancer are as low as 20%. Awareness of the major risk factors of mouth cancer is as low as 8%. So what can we do to make a difference? We can make a huge difference. As dental professionals, dental nurses, dental hygienists, dental therapists, dentists, we all have a role to play in this, and we can all raise awareness. So where can we go for guidelines? So delivering better oral health guidelines, the recent volume, easy to download. There's an oral cancer section in there. I was kindly invited to be part of on behalf of BSDHT to be part of this. And it was a really interesting process to hear about the research, the grades of the research, and how they wanted this document to be set out. So about early intervention, prevention, and I was pushing with the patient there for aftercare. So it's really important for aftercare for our patients who've had head and neck cancer treatment for when they come back to primary care and how we look after them. But it's an interesting document, so please feel free to go to this, and chapter 6 is the oral cancer section. So what are the risks? So we know that UV sunlight, skin cancers, lip cancers, we need to be monitoring our patients. So as Imi said, when you meet them in the waiting room, I always use what she's mentioned because I loved Imogen's article she wrote about empathy and greeting your patients saying, lovely to see you. I use that all the time, and I mention it all the time, Imi. So thank you very much. Your article is fabulous. But we have to look at patients. So when we get them into the surgery, we are kind of scanning their faces. And when they're lying back in the chair, we're looking at the tops of the ears. Maybe a gentleman hasn't got very much hair. We're looking at the top of the heads, or maybe at the nose. We're looking at the sides of the under here, on the cheeks, you know, the typical places. Whereas children, where we didn't have the sun protection factor creams to put on, we may well have frazzled. And did we burn? Absolutely, we did burn. Is that right? No. And are we going to see that risk increase? 100%. So it's important that we ask patients, oh, are you aware of that little mark there? Or are you aware of that on the top of your ears? Or your dental nurse who might be assisting you as a dental hygienist, dental therapist might be poking you and going, can you just check this side of the head, please? So it's working as a team. There's no I in team. We work as a team. So anything that a patient might spot, or a dental nurse might spot, or even receptionist might say, oh, could you just check that patient? Everybody talk together. I always think, have a champion in the practice. Make sure that there's somebody that takes this particular topic. Everybody sings from the same song sheet. But risks, yes. UV, we've all been frazzled. Obviously, slip, slap, slop. We need to be encouraging people to be using sun protection factor, to be using lip balms with sun protection factor. So that's a risk. And coming through, low evidence at the moment, but diet, obesity, and poor oral health. So as we know, there are many patients we need to have discussions with about not just oral health. It's about many things. It's about holistic healthcare. So maybe there is an opportunity to mention about diabetes and oral health, periodontal disease and oral health. You know, it all ties in. So this is potentially coming through as a risk for oral cancer. What about our patients who are smoking? So do we say to them, are you smoking? But do we say, are you smoking tobacco or using tobacco products? Are you using the different kinds of options for vaping now? Do we extend our medical history form to just discuss more of these things? And do we know where to signpost our patients to? Make sure you know where your local options are and have them available. In case a patient says, yes, actually, I was thinking about giving up. January the 1st might be their time for giving up. Make sure you give them that information or signpost them or email them later. You know, have that to hand. What about alcohol? So are you asking your patients, do they drink alcohol? Yes. Do you ask them how many units do they drink? Do they know what a unit is? Make sure that you are okay with knowing what units are. So a bottle of wine could be 9 units, depending on the percentage of alcohol in a bottle. A shot is 1. You know, make sure you know what units are, but talk about alcohol, because we know alcohol and smoking tobacco products together can raise the risk between 10 and 30 times. It's important to have these conversations. But are you confident in talking about HPV and the HPV vaccinations? I talk to all of my patients about the vaccinations. It's very important that they're aware that children at 12, 13 are being offered the vaccinations, boys and girls. It used to be 3 vaccinations, now 2, down to 1 vaccination now. Girls have been vaccinated since 2008, boys since 2019. Boys should have been vaccinated at the beginning, but also be comfortable with mentioning it to your homosexuals that are 45 and under, because they can also qualify for the vaccine too. Conversations that we never were taught about when we qualified many years ago, but you need to get your patter going. Try it with your new patients, because they don't know what your patter is, so you can give this information. It's really important. Get your patter going. And if you look at the uptake of the HPV vaccination, this is post-COVID. So this is 2023, 2024. So this is the girls. So you don't really need to know the numbers, but if you look at this atlas of the UK, you know that the darkest areas are where we are hitting the figures that we need. So this is girls. So very little of the UK is actually a very dark colour. But when I show you the next slide, this is the boys. It's not good. Now, I know this is for a number of reasons. People are questioning about vaccines since COVID and all the information that was certainly even on the news as I was driving home tonight. Are they thinking that is promoting promiscuity? Are they thinking it's only for the girls for cervical cancer? So I mentioned to my patients the HPV vaccination, it's to lower the risk, not just for cervical cancer, it's for head and neck cancer, penile cancer, and anal cancer. And they go, gosh, crikey, Joss, I've only come here to get my teeth cleaned. But actually, we are healthcare professionals. We've done a head and neck examination. We've mentioned why we're doing it. Please don't call it a soft tissue check. I don't like the name soft tissue check because it doesn't register anything with the patient. When I have my boobs checked, I don't have a soft tissue check of my boobs, and prostate check isn't just about a soft tissue check of the prostate. It's a head and neck cancer screening for the head and neck. So please talk about that, but I won't talk about that too much because Alison will cover this shortly. But this is the 2 atlases, so it's really interesting to see the differences of what's the boys' uptake and the girls' uptake is. So more that you promote it, they may be 18, going to university and think, actually, I might go and get that vaccination that the hygienist might have mentioned or the dental nurse might have mentioned. It's every opportunity, make every contact count. So what do we do for our patients post-treatment? So I like this article that's College of General Dentistry's journal, because there was these 2 authors that looked at the websites of dental practices within 5 miles of Manchester Hospital. And they were looking at, were the practices mentioning risks? Were they mentioning intraoral, extraoral examinations? Were they talking about signs and symptoms? And it's really interesting at how little those websites actually had on them. So I would encourage somebody at the practice to go back and look at the websites and promote this information. So if you don't have time in your appointments, make sure that you've got the information somewhere so you can send the links to patients. Patients post-treatment will want to go to a practice that's already talking about this, because they know then that they're aware, they care, so they've put it on their website. So please make sure that you go back to your practice and discuss this. I think it's a great article, because with increasing numbers of oral cancer diagnoses and guidance recommending that patients approach their doctors or dentists or dental hygienists or dental therapists for assessments, when searching for information regarding mouth cancer, patients may first look at their dental practice website, and this study aimed to evaluate the variance of patient information provided regarding oral cancer on dental practice websites. So please have a look at your practice websites to see what's on there, because late effects. Have you heard of late effects? So side effects often happen for patients during treatment and up to about 3, possibly 6 months afterwards. However, post 6 months, they become late effects. How many late effects are there? Potentially 60. Now, this could happen for all cancer patients or patients who've had treatment. It could be for breast or prostate or whatever kind of cancer treatment they've had. But head and neck cancer patients are the ones with the most common late effect for longer. So there are now growing around the UK late effects service. So have a look at your hospitals close to you, see if there's a late effects service available. Have a look at what they offer. Emma Hallam is the Macmillan consultant radiographer who's been driving this for quite a while now, an inspirational lady. If ever you get the chance to listen to her, she's fabulous. And she's driving this service. And in different parts of the country, they're really pushing for late effects for head and neck cancer patients to be a sole service, because this is the most common patients that they will see. And whether it's a late effect that's quite soon after treatment, so 6 to 12 months, or whether it's 5 or 10 years post-treatment, they can always be seen at these late effects service. But I think these need to be all the way around the UK for every patient who's had cancer treatment, but certainly for our head and neck cancer patients. So please, I'm winding up now. So please perform routine head and neck cancer screenings on all patients. That's dentists, dental hygienists, dental therapists. Please tell your patients what you are doing and why. It will get easier to talk about cancer. I won't brush over this because I know Alison's going to cover this part. Talk about HPV and HPV vaccination. So find that link. I often send out the NHS links, so whether it's grandparents wanting to know what their grandchildren have been offered at school, whether it's homosexuals, whether it's all kinds of patients that just want to know about this vaccine. I send out these links that are available quite easily on the NHS websites. Ask all of your team to be vigilant and to mention anything they see. It could be on the lip, the scalp, the tops of the ears. It could be something that a patient's mentioned, because there's a financial implication for continued care. And do the patients, our head and neck cancer patients, get support with that? No, they don't. And I would like to see that change in the future. So thank you very much for listening. I'm going to stop and stop sharing my section now. Thank you.
Thank you very much, Jocelyn. And what we might do is maybe just even do a references signposting list. If you have anything like that, we can maybe put it on the posts for people. Thank you, Joss. And Alison, are you ready to share?
I am ready to share. Yep, absolutely. Can you see that at all?
It'll probably come in a second.
Is it coming up?
Not just yet.
Let me just come out of that again. Come back down into Zoom. I hit the share button and it's not doing anything for me. There we go. Let's try this one. Oh. Now I've lost everything.
Do you have it open on the desktop?
No, well, I did have it on the desktop and now everything's disappeared for me. So I don't know what has happened there. Let me just get my desktop. Right. But, right. Can you see my screen?
It's coming now.
It's coming now. Right. From the
There we
beginning.
are.
Okay. And there we go. Okay, okay. So you will just have to bear with me a little bit because I've got a cold. So if I start coughing, I'll try not to. But good evening. Thank you for inviting me. I've entitled it The Eruption for many reasons, really. You could actually probably call this an eruption with the NHS services, access to dentistry. But really, I really want to look at where we are post-COVID and some of the situations that we were falling into when we went through. We were in the COVID pandemic, really. So I'm not going to go on too much about me. We've already done our introductions, but most of why I'm so interested in head and neck cancer is when I did my BSc, and it was looking at I did an actual research project at practice, looking at why are all these figures going up. We're doing these, as Joss says, these soft tissue checks, and are we just tick boxing? And when we entered the COVID-19 kind of pandemic, there was lots of papers starting to be written, letters into journals, because referrals weren't going in. And we found that there was a drop in referrals by up to 47%. That was in Wales, and I think for England, Scotland, and Northern Ireland, the referrals in was down by 30 to 36% in that period. And we had other things that were happening that were going to be causing the situation. This caused us to have a delayed diagnosis. We had more advanced disease diagnosis was seen internationally. So it wasn't just us, this was worldwide. We were finding that there was late diagnosis, and which obviously means that we are going to have poorer outcomes. During the pandemic, there was an increased smoking and drinking, and there was reduced uptake of the HP vaccine. And as Joss has mentioned, we actually have had this situation where we've got some anti-vaxxers, and it's caused a problem looking towards the future. We also had a backlog of patients to be seen in dental practice. I think for most of us, we were lucky as dental hygienists and dental therapists. You could risk assess your patient if they were high risk for perio and they had systemic conditions. Then we could see them first of all. But then, of course, we had to see emergencies. Then it was the delayed dental treatment. And for where I live in Cornwall, we are a bit of a dental desert, and we actually have we're obviously a poorer area as well, and we have lack of access to dental care. And we do find ourselves here having quite a high number of head and neck cancer cases, and less access to dental care. So what are the studies are saying? Well, as Joss has gone over, we've had an increase of mouth cancer over the last 10 years by up to 49%. We know that early detection gives us improved survival rates. But interestingly, we have the potential to reduce that by a third, if we were to be talking to our patients and actually giving them the risk factors and what to look out for. We as healthcare professionals, and I take that as healthcare professionals, not just being dental care professionals, but healthcare professionals are best placed to deliver this, is always better if we give the advice with a demonstration and some literature. And as Josh has already said, the major signs and symptoms are as low as 20%, or major risk factors as low as 20%, and as low as 9% for the awareness. So when I was looking at my actual research project, the questions that I was asking myself were: oral cancer's rising. Are patients aware? What can we do to help? Could patients do something to help themselves? I mean, at the end of the day, their body is their responsibility. What stops the advice being given? Aren't we getting the information out there? Are my colleagues talking about oral cancer? Colleagues were quite interesting. The dental nurses didn't feel they had enough knowledge or training to discuss oral cancer or self-screening. I actually kind of disagree with that in a way. I think it's more because they aren't allowed to give their patter. When I help with those training to do oral health education, they get really anxious talking to patients, but actually once they get going, they know a lot. So they are actually a really good asset to the practices, and I don't think we look into that enough. At routine examinations, the clinicians didn't even think of discussing oral cancer self-screenings or signs and symptoms of oral cancer. It is and was a tick boxing exercise, and just someone just unsure how to approach the subject. Patients' feedback, this is only within my practice, but this is backed up by other studies, larger studies. Patients weren't really sure. I asked them what they thought I was doing. They thought I was probably looking at their gums, etc., and oral health. 10% only thought I was looking for a mouth cancer screening. These are back in the days before I actually even spoke about mouth cancer with the patients. And 10% didn't really have a clue what I was doing, which is not very encouraging. But they were all, once I'd shown them how to assess their mouths, what to look for, signs, symptoms, etc., they were all much more confident to assess their own mouth about once a month at home, which is what we advise. Additional questions were asked, and they all thought that regardless of the risk factors, so whether they smoke and drank, that they should carry out a self-screening. Risk shouldn't really come into it. and all of them really likened it to breast awareness. They're used to the other campaigns that we've seen, and a lot of them thought the mouth was an easy area to access, although I actually find looking at my own palate is not quite as easy. Um, and they didn't really think that there was anything that would stop them from looking. The thought that they might find something didn't put them off. They were all aware, as all these other campaigns have pointed out, that early detection, they'll have a better outcome if something was found. I had asked them if they were happy for me to contact them in a month to see if they'd carried out a mouth cancer screening themselves, looked for themselves, and they were all happy to be contacted. So what do the studies say? And it kind of backs up what I'd found. Patients were unaware that they're being screened for oral cancer, but they welcomed this being discussed with them. And this was including the risks, knowing how to reduce their risks. Patients aren't anxious about talking about oral cancer, but we are. Clinicians have, when they've been surveyed, they need more training. They feel as though they need more training to approach the subject about mouth cancer. So this is before we've even got to the patient who's got head and neck cancer, and it's part of their life and journey. This is just talking about screening for it and knowing the risks factors. Um, Self-screening may not be as accurate. Susanna Scott, who's done a lot of work at King's, she's now at Queen Mary's, she found that maybe the results that were coming out that it may not work. This was exactly the same with breast cancer when they were looking at this. But with breast cancer, 50% of lumps are found by the patient at home. And that was from a systematic review. So when we go along for mammograms, they can find the smaller lesions, but often patients are going to be finding those lumps and bumps themselves. So it doesn't mean that it's an excuse not to talk about it or patients not to carry out self-screening. So it then brings us about how to talk to patients. Susanna Scott designed something which was an ABCDE approach to speaking to patients. And I'm really just going to touch very briefly on the ABC. Say cancer. As part of our checkup today, we're going to do a mouth cancer screening, just as Josh has said. We may sit with the students going, we're doing an intraoral soft tissue screening. Just say what you're doing. They need to understand what we're doing. Raise the awareness. You have the discussion. They may know something about it anyway. So if you say that and just say to the patient, do you know anything about it? Have you heard anything about this before? You might be surprised and they know something or somebody. Often, though, they'll say, no, I know nothing about it. Didn't even know that you were carrying this out. Have a plan with them. Have your mantra, but have a plan with them. Talk to them about it and say to them, my way I work with my patients is those when we initially do a mouth cancer screening, as I do the screening, I give them a mirror and we walk around and we talk about it. And I talk to them about what we're looking for lumps and bumps and ulcers. But I ask them if they notice anything, mark it on the calendar, come back to it in 3 weeks. If it's gone, forget it. If it's not gone, get one of us to check it. If we're still unsure, we will always offer the referral and we will carry that out. So it's actually having that conversation and also include the throat. Don't just look at the head and the neck. Talk about the throat. If they got a cough, sore throat, hoarse throat, how long has it been there? Did it just appear? Have they had a cold, COVID around it? Those are the sorts of things that you need to be talking to them about and who to contact. Even patients who've got a dentist will quite often go to the GP, and GPs, when I work with the undergraduates, with the dental and medical, they do panic when the medical students, when they think that a patient is coming to them to talk to them about head and neck cancer because they haven't as got as much training as ourselves. But my patients now, because I talk about it to them so frequently, they just walk in the door and go no and no. But equally, they are very open about talking about it. So, yeah, it's uncomfortable for us, but it's not uncomfortable for the patient. And I think if you can just start to talk about it and feel more open about talking about it, we will move on greatly. Um, I'm going to say thank you for listening. This is just some photos that were taken just back last month. We did an initiative from the Peninsula Dental School with the Royal Cornwall Hospital in the foyer, putting up a stand for mouth cancer awareness. We had a chap came up who had head and neck cancer, he had throat cancer, and it started from just having a hoarse voice. It was really good today. We had lots of interaction, not only with patients, but actually with staff members who weren't aware so much of how to talk, what to talk about. But I'd just like to say thank you to the Mouth Cancer Foundation for supporting me with that. And that brings me to a close. Thank you for listening. I'm going to stop sharing my screen there.
Thank you. That's very interesting. Thanks very much, Alison. I'm sure there'll be questions for you in a couple of minutes. And I'm going to hand straight over to Emma. Thanks very much, Emma.
Thanks, guys. I'm going to do this a bit differently, if that's all right. I'm not going to do a PowerPoint. I'm just going to do a bit from the heart. And can I just read you a paragraph that has come from a manager of a care home about a head and neck patient? A resident that currently resides with us brought to my attention that her mouth was sore. She'd taken a denture out and tried to scrape off some fixative with a fingernail. After taking a closer look, I found that they looked to be like an abnormal structure inside her mouth. I asked a healthcare visitor, a professional, somebody who came in every now and again to look at our residents, to have a look and advise me further. He told me that it was really important to get a GP to see it, as it looked like it required further investigation. I contacted the GP surgery to be told by the receptionist that this was a mouth problem and to find a dentist. You know where this is going now, you lot, don't you? I wasn't happy, as the resident also stated that she was finding it a little bit difficult to swallow. I contacted the GP again and demanded that they came out to see her. The GP arrived and I again stated to call a dentist, and if you can't get one, ring 111. I rang 5 local dentists, explained how important it was for the lady to be seen. I explained that she had poor mobility and needed a domiciliary appointment. Not one dental practice would accommodate her, as none of them had a domiciliary contract and they had no insurance to do this. I stated that it was important and I was prepared to pay private for an emergency appointment and book a wheelchair taxi to take to the dentist, even though I explained that this lady finds it very difficult to leave home and it would cause her such distress. We felt we needed to get her seen by a professional. Not one single practice or professional from a dental background helped us at all. Why are our elderly second-class citizens? Are their mouths, gums, teeth or health not as important as others? After a 2-day agonising wait, we managed to get an appointment with an emergency dentist. As this is ongoing, I'm unable to provide further information, but I wanted to feed this back to you. That's a real life person. I actually know that Doreen, she doesn't mind, the family don't mind me telling you, has passed away. And what we did in the end was we took her down to A&E. So she sat in A&E. And there was nothing you could do for this lady because it was really fast growing. It was on a pallet and it was occluding her airway, and it was scary. It was really, really scary, not only for her, but for the professionals, and I call them professionals, the guys living and working and looking after these individuals in care homes. So my little talk today, and I'm not going to go on long, if you do one thing is not forget the older population. The term elderly now is not allowed, and I keep slipping up, guys. It's not just, I keep saying it without thinking. Elderly is seen as, it's discrimination calling them that. So in about 1995, I think they changed the word to the older person. And I think it's so important that we look after this group of individuals. I have got 2 in Rochdale over the age of 60, well, they're in their 80s with mouth cancers, and I was on the phone today with Age UK because I do a lot of work with Age UK. They have got 2 residents in care homes with dementia in Salford with mouth cancers. So I personally think there needs to be a lot of work around how we upskill people within care homes. Please don't think I'm going on about care homes, because actually since 2011 to 2021, we've seen a decrease in people who are needing care homes, not nursing care, but we've seen a decrease. So there's a lot of people over the age of 65, and the guys here will tell you a lot of people over 65 have head and neck and mouth cancers. But I think there needs to be more work done within primary care on looking out for these conditions in the mouth. If you go on I Am the Mouth Cancer Foundation's older person, even though I look really young, I'm the older person rep for this, because it's something that's really, really close to my heart. And there's a video on there showing staff how to look, listen and observe for a mouth cancer, because they can't lie back in a chair. They won't open their mouth very easily. So it's about, I think one of the guys said, it's about just looking at that person and just figuring out, is there something different? Asking their wife, carers, daughters, carers in the homes, is there anything different about them? Sometimes family know there's been a change, and it could be something that's going on in the mouth. I'm here also to plug something called Empowered Conversations, and they taught me so much, because in my experience with people over a certain age, especially with cognitive issues like dementia, if they get a mouth cancer, they go completely into themselves. So it's figuring out how to communicate with them non-verbally. If any of you are interested, the course is Empowered Conversation. I'm using it with my mum at the minute, because my mum's got dementia, and it's communicating with her when she can't verbally talk to me. Does that make sense? Sometimes she has a certain thing she picks with her fingers. If you do that back to her, she'll do it back to me. So it's communicating. There's loads of little tips, and like Siobhan said, maybe we need to do another course at some point on how to deal with this. But I am here championing this amazing group of individuals. I remember I lost my dad last December, and I remember sitting with him in one hospital appointment. He said, they judge me before I even walk in that treatment room and that clinic. And he's right. It's human nature. You see that medical, you see their prescription list, you see their folder. I'm too old. I remember big patient notes. You do tend to see them differently. Nothing about me without me. That's the one thing I would say, and these people deserve treating the same as anybody else. I know a lot of them will be palliative. I know it's about keeping them not going, but it's about a good death. And I don't want to end tonight thinking about death and us passing, but it's going to happen to us all. They deserve a good death. And just before I go, one of my close friends' dad died last night with a head and neck cancer, one of the biggest tumours I'd ever seen, in his nose. And she told me to tell you tonight, if that cancer had been anywhere else, he would not have just been thrown at home to just sit there. The carers coming in from these care agencies are absolutely fantastic, but they don't know how to deal with this. He was 92. He'd had a fantastic life. She says, don't feel sorry for him. It was a bit of a one. But her message tonight was, we need to treat head and neck cancer like a cancer anywhere else in the human body. Yeah. And that's me. I hope I've caught up with time, Siobhan. I didn't want to go on too much.
Oh no, we could listen to you all evening,
very
Emma.
much.
Yeah. There's people asking about that empowering conversation. Will you give us a link for that?
I'll send you the link.
Or put it into the chat here now if you have it there.
I'll try and find it. I actually do fundraising for them. So if I do my runs or walks, Joss knows what I'm like. Half goes to the Mouth Cancer Foundation, half goes to Empowered Conversations. They are phenomenal. And I'm not embarrassed to say I have counselling now every month, because to understand how my mum's developing. And okay. they sort of support you with that. But as healthcare professionals, any of you on here, they are brilliant, and they're only a little small organisation, so please support them. And I'll bob the link in. Sorry, I'm talking too much, and I'm a celebrity.
Well, maybe we need to try and do some fundraising or something to support that, Emma.
Thank you so much.
Absolutely fabulous presentations tonight. Thank you for being amazing professionals for head and neck cancer patients, and would love to know more about the empowering conversations. Just while we're chatting, I'm going to just put the slide up in case anybody wants to go. Can you see that slide? Yeah, you can see it now? Come on in there, Joss and Alison. So on the slide on the right-hand side, there's a QR code. If you scan that, it'll take us straight through to answer the questions, tick all the boxes. On the left-hand side is a code for the NSK shop. Because this is education, NSK give 40% off, and you can get your code there and visit the shop and so on. And I'll put a link as well into the chat box for you, just in case your QR code isn't working. Thoughts, everybody? What I always find this one quite emotional, really. Do you know what I mean? It really makes you think again. I've had somebody in the family go through cancer care treatment the last year since this webinar. He absolutely had fantastic care. But I also had a friend that died, and it was throat cancer that wasn't caught in time, that then went to the lung, unfortunately. So much can just happen in a short space of time if it's not caught early. Do you want
I
to come
always
in on
think
that, Joss?
when we're seeing our patients in the surgery and we're giving them this information, it doesn't just stop at them. Any of our education that we share in the surgery doesn't just stop with them. They share it with their family, their friends, their work colleagues. Somebody might mention something on a dog walk, or, oh, I've had this lump here, or this ulcer's been around for a while, and they will know because we've lectured them and taught them and trained them that, you know, that needs looking at. Whatever it is, it's been there for a while, that needs looking at. So, yeah. Don't worry about sharing. Do something. Do something.
I'm a great believer I always say to my patients when I've done their head and neck cancer check and we've gone over about risks, signs, symptoms, etc. I always say to them, it's not about you, it's about what you will do with that information. Because I said, your neighbour will nip in for a coffee and they'll tell you they've had an ulcer for 6 months. Now what would you do? And she said, God, she said, I'll have something, but I had a patient who I see every 3 months. And in that 3 months, this is how quickly it can change. He came in and said he'd got some lumps in his neck. At that point, I felt them and went and got the dentist, went to go to get the dentist because I always like somebody to back up with me. And I hadn't finished checking. He came in very quickly, said, oh, I think that's a GP referral. Then when I opened his mouth, I actually saw the lesion coming from his throat into his mouth. All the necessary checks. We're really lucky down in Cornwall because you can phone up for advice from the doctor on the day from Max Fax and oral surgery. So we agreed that I would send in the referral, but it probably did need to come from the GP as well, just as a double whammy really for ENT. What I always do when I do send in an urgent referral is I always phone the patient to double check that they haven't got lost in the system. And the day I phoned, he was going in for his pre-op, but it wasn't his pre-op for his neck or his throat cancer. It was the pre-op for the bowel cancer that they'd found, because they'd done a CAT scan and they weren't related. It wasn't a secondary. And just from finding that, we found his bowel cancer. So we're 5 years on. He had to have a colostomy. That's all been reversed. Yeah, he has his aftercare issues with mucus and lymphedema, etc. But he lives a life, So catch it early. It might not just be head and neck cancer that you're catching early. It might be other cancers that are within the body, and they're not always going to be related. It was just luck, pure luck.
Yeah, and also the quality of patient life is massively affected by how quickly we are diagnosing these things. And best case scenario, you send them. I had a patient only a couple of months ago who came in who had a history of cancer, and she had a lump in her neck. And it turned out to just be a fatty lymphoma that was nothing to be concerned about at all. So that's best case scenario, but it's better to be safe than sorry, because all of us who are seen cancer patients, we know that those patients that are lucky and it is caught early, perhaps in a hygienist appointment from an ulcer, their quality of life could go back to almost normal. And those who are caught later, it's catastrophic.
And I do like that when you say in the waiting room, like I said earlier, Imogen, Just remind us again what you say when you go into the waiting room.
I say, it's lovely to see you. Come on in, rather than how are you?
Anything else?
For me, it feels more comfortable across beyond just this topic, because I think as hygienists, we are very approachable, and patients do like to sometimes share really personal things with us. And it's not always about cancer. It's always, you know, be any sort of thing they could be having going on in their life. And sometimes that is a bit of a trigger question. Hi, how are you? You know, in a busy waiting room, it's not always what people want to hear.
And it's funny you should say that. I'm mentioning the Empowered course again. They teach you not to ask somebody with dementia, how are you?
Yeah.
You can't cope with that.
And Emma's put that link into the chat for anybody that wants to. That was absolutely fabulous session. Thank you, Imogen. It makes a big difference. Any questions out there?
Can I just say, while you're looking at the questions, is for those of our patients that do have head and neck cancer, please keep an eye out for their carers, because they're going through it as well, and it's hard for them. And this is the same if you've got dementia, Alzheimer's patients. You know, keep an eye out for the carer, because I often actually, the chap that I was just talking about, I used to actually phone and check in on his wife, because you know they are the unseen hero there. You know, the patient's going through a lot, but please remember their carers.
Yeah, and their families as well. It's very isolating for the people around them.
Emma, what have you got on next? You're always doing something. You're always...
Well, funnily, thank you for asking. A talk's been dumped on me and you, hasn't it, on Saturday, the 10th anniversary for the Society of British Dental Nurses. And funnily enough, all I'm going to do is play so my mum now doesn't know who I am. She looks at me and she goes, I know I like you, but I don't know who you are. So it's gone that far now with mum. However, and some of you might have seen the clip, a few months ago, because she was a dental nurse, I've got her a uniform with her name on, and I plonked some alginate in front of her with an upper tray, and she mixed that and loaded the tray like that. So as it's a dental nursing day, I'm going to show that video, once a dental nurse, and you guys know that, always a dental nurse, and it never leaves you. And it's fascinating with the dementia, where it's ravaged her brain, but there's a little section there for dentistry. And if you said to her, Mum, your next patient's there, she'd be off. So honestly, that's all I'm showing is that video, because I think it's really powerful, and you can apply that to any profession. But yeah, that's what I'm doing on Saturday, because I think that says it all, doesn't it? Really?
Definitely. Somebody has a raised hand here. Do you want to put it into the chat, Publica? Well said, Alison, regarding the partners and carers of the patients. And yeah, Saturday, so
Sorry.
We'll be in Manchester on Saturday with the Society of British Dental Nurses celebrating 10 years, which will be lovely. So we wish them all the best on Saturday. As Emma just said, we've been roped in to give a little talk, which is 15 minutes. That's nice, isn't it?
Yeah, lovely.
Yeah. Well, I think we'll finish there if we don't have any more questions. Emma, Joss, Alison and Imogen, thanks a million again. And I think we'll ask the audience if they'd like more or longer on different sections, and we'll definitely see you again same time next year if you're all up for it again.
Thank you very much for hosting it, Siobhan.
Thank you very much.
I see a patient who is PEG fed. He has multiple rounds of radiotherapy and suffers with severe serostomia. He's also no voice due to severity of the therapy he's received. I struggle with how to treat in general practice, as we are hand scaling only due to the risk of using ultrasonic with water. Any advice on how to treat the amount of calculus? It's difficult to remove just hand scaling.
Personally, for me, I would say the most important bit is the regular removal of biofilm. Calculus can stay there, it's not an issue, but it's just about not allowing that biofilm to be aspirated. and to keep the mouth as clean as possible, help the patient as much as possible, give them ideas. If they're able to clean themselves, if they're not, help their caregivers to help the patient, make sure they've got the right size toothbrushes, make sure they've got the high fluoride toothpaste. They should be on that high fluoride toothpaste for the rest of their life as being a radiotherapy head and neck cancer patient. That would be my ideas. Anything from you yourselves?
Absolutely agree with you, Joss. I think it's all about biofilm disruption, and you can get good gingival health around calculus if you've got effective biofilm. The only thing is obviously if it's a wall-to-wall calculus situation and it's preventing interproximal cleaning. So my advice would be sit the patient upright. It's not ideal for our back health, but it's essential for these patients. Make sure you've got a nurse with high volume aspiration, even if you're hand scaling. And personally, I've done a few patients like this, and even in community special care, we see a lot of patients who are aspiration risk. Sometimes it is possible, depending on the case, to use very, very low level water on an ultrasonic scaler around the anteriors, for example, if the patient is sitting completely upright with their chin down, and you can use a kidney bowl underneath so that it's dripping into the kidney bowl with high volume. Sometimes that's not appropriate depending on how high aspiration risk they are. But it may be worth considering something like that, just to try and get those heavier pieces off so that you can then get a TP in there. Dr. Barman's brush is also really helpful for patients like that.
Okay. Thank you. It was a wonderful and thoroughly enjoyed the session. Thank you. Somebody said Clinicet pre-wash, and thank you again. I'm going to end there. It's 10 to 9. Thank you very much. We appreciate you giving up your time. Have a good evening, everybody, and we'll see you in a couple of weeks. Take care now. Bye-bye.
Thank you.